Teşekkür ederim.
Thank you, Mr. Chairman. I participated at the first two meetings of the psychopharmacology congresses, and I think we have come a long way. We have become such an international event, and for this I'd like to extend my gratitude to Oğuz and his team, and hopefully in the future we will have more events like this, and hopefully this will enable us to engage in cooperation with our international counterparts. Today I'll be talking about smoking in schizophrenia patients. Our colleague talked about morbidity, mortality, cardiovascular risk factors, and so on. And when we look at our day-to-day practice, when we work with schizophrenia patients, especially patients above the age of 40 or 50, sadly we don't have many such patients. There are two reasons why this is the case. First of all, the severity of the disease decreases over time, but secondly, the patients have a low life expectancy. Compared to the normal population, it is 20 or 25 years less, and the patients die when they're 50 or 55. And they are 1.5 to 3 times at a greater mortality risk compared to the normal populations. And of course the risk factors are metabolic syndrome, lifestyle, and smoking. But funnily enough, smoking has a known effect in schizophrenia patients or other mental disorder patients, but sadly we don't have many studies on this issue on smoking in schizophrenia patients, and we need more studies. In the last couple of years, another prominent issue is multiple medication use or polypharmacology, and this is also quite prevalent in schizophrenia patients. You have multiple antipsychotic used in schizophrenia patients, or other psychopharmacologic agents are used, and this also causes an early death. So, what can we say about smoking? What's the problem about smoking? Between the ages of 35 and 54, smoking increases your risk of mortality by 2.6%, and in schizophrenia patients, 60 to 80% of schizophrenia patients are smokers, and this was conducted in Eastern Germany, and this focuses, the part I'm going to share focuses on schizophrenia patients only, about daily habits of these patients compared to the normal populations. In schizophrenia patients, you have a statistically significant rate of higher smoking, and also smoking is 2 to 4 folds higher compared to the general population, and 60 to 80% of these patients are smokers, and also these patients are hardcore smokers, because there are so many different studies that looked at plasma nicotine levels. They take a very deep drag, and they inhale a larger volume of nicotine, and they take more frequent puffs out of the cigarettes. And also the patients do not necessarily understand the negative effects of smoking on their health because of cognitive functionality restrictions in these patients. And there is an etiologic link between smoking and schizophrenia. People who are heavy smokers compared to non-smokers develop schizophrenia 2 times more. And early smokers, early onset smokers, or heavy smokers compared to non-smokers develop psychotic episodes compared to non-smokers. So smoking deteriorates the current situation of the patients, but maybe it is seen by patients as a self-medication, but it also triggers psychosis. But why do schizophrenia patients smoke? There are so many different theories, but the theory that is accepted widely is self-medication, the theory of self-medication, because smoking gives you a dopaminergic stimulation and it increases attention. In animal tests, this has been clearly demonstrated. Nicotine significantly increases attention in animals, and cognitive functions or other adverse effects are perhaps alleviated with smoking, and smoking reduces the plasma blood levels of antipsychotics, and this reduces the side effects of these antipsychotics. So maybe in order to alleviate the side effects or relieve these side effects, the patients self-medicate themselves by smoking. Also, there are other studies. Smokers that are schizophrenia patients have better cognitive skills. This is a comparison between non-smokers and smokers, and this goes to show that smokers with schizophrenia have better cognitive functions, especially in certain types of cognitive tests. Schizophrenia patients that are smokers fare much better compared to non-smokers. In the Iowa gambling test, female schizophrenia patients that are smokers compared to non-smokers have a higher performance, and this has also been demonstrated. So maybe with smokers, the patients are trying to correct or improve their cognitive functionalities, especially clozapine and serotonin antagonists have been subject to certain tests, and we have some data that does not clearly demonstrate the link. There are a couple of treatment options that have become prominent in the last couple of years. One is motivational interview plus cognitive behavioral therapy, transdermal nicotine patches, and two important medications that can be used that haven't been used in schizophrenia patients, bupropion and varenicline. The commercial name is Champix, and both of these agents are available in Turkey. So in these treatment studies, what are the results? This is quite interesting. You have two groups here. One is, in one group there is no intervention, in the other one motivational intervention and CBT was performed. In both of these groups there is a marked effect of the treatment, which goes to show that if you work with your patients, there will be a response to a certain degree. There is no marked difference between the two groups, but there's also one thing that's quite interesting. The response rate deteriorates over time. In smoking studies, the response rates are quite good at the very beginning, but in terms of compliance, there's a big problem, and this applies to other people or other populations as well. Again, a comparison between compliance. There's a difference between patients who remain on treatment and patients who quit the treatment. Bupropion is quite important in this regard. In the first phase, there's group therapy only, and this is the decline in smoking. Group therapy plus well-sustained bupropion, but then you get less compliance, and then sustained release bupropion only. This is a 14-week study, and the success rate continues. Especially about bupropion, we have meta-analyses as well, because there are so many different studies compared to placebo. Especially bupropion in schizophrenia is quite effective in smoking cessation in schizophrenia patients. I'm not going to go into details, but yet another interesting thing about this study is this. With bupropion in positive symptoms, negative symptoms, and depressive symptoms, there is a significant improvement thanks to bupropion. Yet another significant drug is varenicline, and in nicotine withdrawal, this is quite effective. It improves cognitive functions, and it's quite efficacious. But in the last couple of years, certain concerns have been raised in terms of using varenicline in schizophrenia patients. One of these is from FDA. They say that in schizophrenia patients there might be a potential exacerbation of these psychiatric symptoms. And yet another warning is about the cardiovascular system. There might be side effects, they say, but notwithstanding these two caveats, we can use varenicline on our patients. Also, the role of genes in smokers with schizophrenia is also discussed. Serotonin genes, dopaminergic genes, and BDNF genes. Dopaminergic genes, D1, D receptor polymorphism, patients versus patients that do not have it smoke more compared to the second group. Smoking also, well, we are subject to foreign stimuli that are received by our brain, and there is a gate control system, and thalamus is like a sieve, and only the appropriate stimuli is sent to the other parts of the brain. But schizophrenia patients are vulnerable to all sorts of stimuli. They all go to the cortical center and they create chaos. But smoking acts on the gate control system and regulates the malfunction of the gate control system, it is suggested. This system, especially by the cholinergic system, it is regulated, and cholinergic system is essential for cognitive function. And there are many studies conducted on schizophrenia patients. Decreased cholinergic neurotransmission is observed in schizophrenia patients. In postmortem studies, disturbances in nicotinic receptors, receptor expression and function is also observed. Also, increased number of cholinergic neurons, elevated acetylcholine levels are also observed. But of course, that might be the effect of the medicines. Especially there's decreased expression of alpha-7 nicotinic receptors. So schizophrenia entails a cholinergic disruption, and maybe in terms of cognitive functionality, certain new medications might be developed. There are phase 2 and phase 3 studies for negative systems, especially anhedonia, for anhedonia and allergia, alpha-7 nicotinic receptor antagonist medications are being developed as we speak. So finally, here's what I would like to say. We have a very high prevalence of smoking in schizophrenia patients. This increases the risk of mortality. There are so many treatments like bupropion, varenicline, nicotine patches, psychotherapy. These can be coupled. But right now, the success rates haven't been very high. And there's a response at the beginning of the treatment, but in terms of continuity, we have problems. We need new studies, especially we need new medications that can act on the cholinergic system. And there's a link between cholinergic system and dysfunction in schizophrenia. And also in the recent past, there have been new medications in the pipeline that are in the phase 2 and phase 3. Thank you for your attention.